Hello, friends. A very good day to all of you out there, and a very, very warm welcome from the entire team of RFA Tutors. Your mentor this side. Thank you so much for joining in. Warm welcome to all of you. Thank you, Asif, for joining in. Hello, Anju. Hi, Asma. Hi, Aisha Jadoon. Thank you very much, Radhika. Thank you very much for joining in. This series is resumed. We were doing very important questions earlier, November 2025 exam. And we resumed after the exam thinking about that the older stations, everybody has got a very stronger grip upon. You're able to handle, oh, yes, ma'am, it was a repeated station. I could do that. The problem in November 2025 was when the newer stations were coming up. So we had a meeting internally in the team and we decided that, of course, the premium, the fast track, you guys get skilled in all the topics that are important, high yield, repeated ones. So in the open coaching, we would do pick up from 2025 October publications and start doing the expected talk articles, which would be expected news stations, so that you are skilled to know and handle the patients who are new in exam and the upcoming talk article topics. So by the time you would be taking exam in May, you would be done with very high yield, not repeated, but expected stations for exam May 2026. For that series, the entire RFA Tutors will be with you guys back to back. And to start with that series, I'm here to do the first topic with you guys, which is again one of the recent talk article of the recent publication, borderline ovarian tumor. I'm here to give the candidate instructions. I would solve the station both if it comes as a simulated patient task as a structured discussion. The idea behind this is that you're prepared for all those expected unknown stations. You are skilled in that and will give you perfect keys to solve them and to make you master. That anxiety and stress would be less when all the talk articles would be prepared for you guys. Of course, in the course, we do all the high yield topics. Here, we would do the expected topics, which are the new topics expected in exam as per the changed pattern. All right. All right. We already have a volunteer. Shweta is going to be the role player and Asya is going to be the candidate. Hello. Hi, Asya. How are you?
I'm fine. How are you, ma'am?
I am good. Thank you so much. And how is my role player? Hi, Shweta. How are you doing, my dearest? Can you unmute yourself?
So
Just
I
want to check
might
your.
have a sore throat.
Okay,
I'm
no
having a little sore
problem.
throat. I hope I'm audible.
Absolutely audible. It's okay, Asya. So it's better to manage a role player who's actually going to be a husky voice. That's another exam practice, isn't it?
Yeah,
Yes?
right,
All
right.
right.
Yes.
Great. So many students were saying in the second round, ma'am, the role player was yawning, the role player was like this, and the role player was lying down and hardly nodding head. So you should be knowing that expected, if at all you are in the second part and afternoon circuit, the chances are that you might not get a very good acting because the role players tend to get tired from all day practices. All right, let's start, ladies and gentlemen. And anybody who wants to volunteer for the next sessions, upcoming sessions would be from October 2025 talk article publications. When we'll finish that, then we'll go behind. And I'm going to take then Safa, Gori, Pagalu, everybody's going to take one by one with you guys, okay? All right, so the reading time goes. Thank you very much. I can see lots of audience here. Hello, Fadi. How are you? Fatima, good to see you. Hushbu, well done. I want you guys to volunteer for the next sessions, all
Hello,
right? Hello, thank you very much. How are you, Fadi? All good?
fine, fine. Thank you for this session.
Thank you, my dearest. Thank you. 2 minutes reading time for the candidate, please.
It's not moving. All right. Here we go.
Time starts now.
Hello, my name is Dr. Farooq. Am I speaking to Anna Roberts, 34 years old?
Yeah, I'm Anna.
Mm-hmm. And
Yeah,
how
this
would
is
you
Anna.
like
I'm
me to?
34 years old.
All right. And how would you
Anna
like
is
me to
fine.
call you? All right.
Anna is
All right.
fine.
All right, Anna. I have gathered from your notes that you have come to discuss the histopathology report with me, and I'm here. Whatever you want to ask, I'm here to address all the concerns.
Sure, doctor. Yeah.
Mm-hmm. So first of all, I would like to ask that how is the recovery after the laparoscopy?
Oh, the recovery was very well, you know. I didn't have any problem, and I was very happy that post the surgery,
Mm-hmm.
it was a
Mm-hmm.
keyhole surgery, and so I did not get much of pain also. It was all good.
Mm-hmm. All right. It's good to know that you are recovering quite well. Can you please tell me that do you have any idea about your uh, discussion regarding your operative notes or operative findings after the surgery?
No, doctor, I really don't know. I was just told that there was something in the pathology report what I
Mm-hmm.
need to discuss with you, but I really don't know about it. I'm a little
Mm-hmm.
anxious, but I'm sure,
Mm-hmm.
you would be able to help me out with that.
Sure, Anna. This is a very concern because you're anxious, and we are here to help you out, right? Because I was not in the
Okay.
surgery, I would like to ask a couple of questions to know better about you. How's that sound?
Sure, sure. Please go ahead.
All right. Can you please recall what events leads you to come to the hospital for this ovarian cyst that has been removed?
Okay, so it was around a month back. I was with my the daily routine. So
Mm-hmm.
I just come back from school. I'm a school teacher.
Mm-hmm. Mm-hmm.
Just take tea.
You want a glass of water?
Hmm, Sorry.
Are you okay?
So yeah, I'm fine. So when I
Mm-hmm.
came back, can you just cancel the time? Just come back in 10 seconds. Huh? Yeah, I'm back. Sorry. Okay, so it so happened that a month back, I was back from my school. I'm a school teacher there. So I suddenly had this sharp pain in the evening. And when I
Mm-hmm.
went to the ER, they did a scan and they said that you've got a cyst inside and that needs to be removed. So I
Mm-hmm.
was taken in the theater and
Mm-hmm.
then, the surgery was done. And after that, everything was fine.
Mm-hmm. So, can you please recall that did they run any test, a blood test, which we usually referred as
Yeah,
CA-125?
they did do some blood tests, which they said is a tumor marker. And later
Mm-hmm.
on, they did tell me the next day that the tumor marker was all normal. So I think that was CA-125, but I'm not sure. They told me that it
Mm-hmm.
was all normal. I was very
Mm-hmm.
happy.
Okay, that's good. All right, Anna, can you please tell me that was that pain was related to vomiting, nausea, or any loss of weight?
No, not really. I just had a pain. I was a little nauseated from a couple of days, but I just thought that it was just a stress of work. But then,
Mm-hmm.
when the sudden pain came over, I realized probably it could have been because of the cyst.
Mm-hmm. Or do you feel any change in your appetite? I mean, is it decreased, or you have changed or noticed any change in that?
No, no, not really, not really.
Mm-hmm. All right. How many kids you've got?
I don't have doctor. In fact, after
Mm-hmm.
the surgery, I was really thinking I want to go ahead for a pregnancy now. I'm already 34
Mm-hmm.
and I think I should go for one.
And did you have taken any treatment for getting pregnant?
No, no, not really. I mean, I
Mhm.
was just thinking that, I would go ahead for a family now after a while.
All right. Okay. Regarding your menstrual history, are your periods are regular?
Yes, doctor, they're very regular, no issues with that.
Mm-hmm. All right. And any GP visits for any conditions like diabetes, hypertension, or asthma? You're taking
No,
any
no, I'm
medications for
very
that?
healthy. I'm very healthy, no
Mm-hmm.
issues at all.
All right. Any history of surgeries down there in the tummy before?
No, doctor, nothing at all.
Mm-hmm. Any family history of the concerns you would like to address here?
Not really, not really. It's all okay in my family.
Mm-hmm. And how's your support at home?
It's nice. My husband is quite supportive, and we've
Mm-hmm.
been living
Mm-hmm.
together for long, so it's been a good journey.
Mm-hmm. So are you up to date with your smears?
Yes, yes, very regular, and they've all been normal up till now.
Mm-hmm. Anything else you want to add on? Any
Not
specific
really.
history? Mm-hmm. So do you
I've been
smoke?
using the double hormone pills for quite some time
Mm-hmm. Mm-hmm. Mm-hmm.
because
For
I didn't want a
contraception.
baby initially in the initial
Mm-hmm.
yeah, in the initial phase of my relationship. So it's been almost 4 years I'm using the double hormone pills, but that's it.
Mm-hmm. All right. So do you smoke
No, no.
or take alcohol?
Very occasionally during parties, but otherwise not. That could be just once or twice a month.
Okay. Pardon me if you're taking any recreational drugs.
Not really, no.
All right. Thank you so much, Anna, for giving me all the information. Now,
Hmm.
I want to ask that are you accompanied with somebody now? Because I have got uh, m- many things to be addressed and to inform you. So I need that you should be having someone to be with you.
No, I'm okay, doctor. I mean, I'm really keen. My husband is out
Mhm,
for work, so I would be happy if you would
mhm,
just go ahead.
I understand. As Anna, I am not having a very good news, but however, I still ask you that you are very in a safe hands, and we are all here to help you out. Okay.
Okay, doctor. Yeah.
Mhm. So, Anna, after confirming your name and NHS number, your histopathology shows a borderline serous ovarian tumor. Are you with me?
Okay. Okay. What is
Mhm.
that, doctor?
Hmm. It is basically a type of the tumor in which the lining that covers the ovary that becomes abnormal. It is not involving the supporting structure of the ovary. However, we cannot say that it is not that cancerous, but we have to treat it with surveillance. Are you with me?
Okay. Okay. Not very clear, doctor. Can you just tell me, like, is it a cancer?
No, that's a very valid question. It is not a cancer. It is something between that. I cannot say that it is a benign, that it is not that harmful, but really it can go towards the stage in which it might invade the surrounding tissues as well.
Okay.
Right? So, giving at the history that you have been trying to conceive as well. So, I would like that you must be referred to the fertility center in order to complete your family. I hope you're understanding. Hello?
Okay.
Okay. And
Hello.
with that,
Yeah.
yes, after the completion of your family, there you might be needing a complete treatment that involves the removal of the ovaries and your womb, unfortunately. I hope it is very difficult to understand and it's a difficult news, but I want to be very honest with you.
Okay.
All right.
Doctor,
So,
are you sure that I don't have a cancer? Or, I mean, I'm really
mhm,
worried. Like, does it
hmm,
need to be
that,
excluded with some tests? Or, I mean, are you sure it's not a cancer right now?
hmm. That is a very valid question, Anna, and I would like to tell you that we'll be running some tests and we'll definitely be putting you on the surveillance. That includes some scans and tumor markers, that is CA125. Along with that, we'll be definitely referring you to the fertility specialist so that you're able to have kids, right? So after the completion of your family, we might be removing the tubes and ovaries along with the womb if we find anything abnormal.
Okay, so
I
you
hope
mean to
you're
say
getting
I
it.
can still have children?
Yes, we will refer you for that reason to the fertility center so that you can conceive easily and we can complete the process of treating this borderline ovarian tumor.
Okay, but doctor, why
Mm-hmm.
did this happen to me? I mean, it's been like such an easy surgery for me. Like, what happened suddenly?
Mm-hmm. Well, it is a very rare form. It occurs in about 30% with the symptoms like simple abdominal pain and the nausea, as you have reported in the ER, right? So it's unfortunate that you have got that. But however, the treatment is surgery, and we have done that, right? So the
Mm-hmm.
only thing is that I would like that you should have a family, and after the completion of the family, we could be referring you with to the MDT, which includes the gynae, the cancer doctors, so that we should be having a very good plan for later on.
Okay.
Okay,
But,
but till now, the important thing is that we have to refer you to the fertility center so that you might get the kids, and then we'll follow up with the
doctor,
scans
what
and
about the
tumor markers.
surgery? Will you do it now or will you do it later? Because it's just the cyst that has been removed. Now, what happens to my ovary? Which,
The
I mean,
ovary, it has been removed, right? You have got one ovary left. So it's best
okay,
that we should be referring you to the fertility center, right?
okay, okay. And will it come
Mm-hmm.
back again to me after that?
Mm-hmm. Well, Anna, its recurrence is very less, like about 2 to 24% it might recur. And that's why I'm saying that you'll be under strict surveillance with the scans along with the tumor markers as well, right?
All
So
right. Thank you
if
very much. My dear. The 10 minutes are over. Thank you,
oh,
Asya. Thank you very much, Shweta. Lovely having you here. What a composed voice, what a composed attire. And thank you very much for being very patient. And how did we come to know from the case scenario that it's been oophorectomy and not cystectomy? I think
Yes.
Shweta was also looking at. How do you know that it's cystectomy, it's oophorectomy and not cystectomy, sweetheart?
Ma'am, she
because
didn't
I
read the notes. You have to read the notes, no? I mean, the operative notes, you didn't say that I'll go through the operative notes, so
I
that
mean to
might be
say
why.
that at the moment you can at least ask her that have you been informed that the ovary had been removed because you don't have
Mhm.
information with you.
Yeah,
Because
yeah,
Right.
if it's cystectomy, is it the right treatment?
right.
Hmm.
That's what I wanted to ask
Cystectomy
you.
is a
Borderline ovarian tumor, can we just do cystectomy and we are complete, is it? Or it has to be USO?
it
It
is a
has to be.
unilateral self-injury.
Thank you very much.
Right?
So in
And
case,
cystectomy, in case if it is bilateral, we have to
But
leave the ovary if the fertility issues are there. So
yeah,
that is the reason I have an idea
Rupa
that
wants to say something. Rupa,
Dr. Sidra, I wonder if the
yeah,
patient needs to preserve the fertility,
correct.
then and if then what? Then
Then we don't remove the bilateral oophorectomy is not done. Then we do USO, the
you, you,
affected
need-
one, and
you
then
need
we do the fertility center referral, and we ask her to complete as early as possible, and then we get back to same as that we do in endometrial hyperplasia with atypia, guys. You know,
yes.
this
Yes.
is what we have to do. But the scenario which I have created, I have not made it clear that it was cystectomy done, because generally for 34 years for a cyst, we'll do
Yeah,
cystectomy, correct?
do
If we
cystectomy.
don't know that it would come out to be a borderline ovarian tumor, we would do cystectomy, correct? So either you touch the point in the history that somebody informed you that what procedure had been done, or you can say we will check into the notes that how it had been, the surgical removal had been, and we'll get back to you so that we are clear about if we need another surgery or not.
All right. Okay.
Do you all understand? Because this is what the
Mm.
applied clinical knowledge is. Overall, very well done for the composed attire and for the sequence of events. I'm very glad and very happy for the acknowledgement and the nodding. Asi, it was much better than the sessions. I've written very good introduction, very good agenda, an open question to start with the information gathering. And when you said, good to know that you're recovering well, you were very confident. I liked your attire when you started, good to know that you're recovering well. That way was very impressive to the examiner. You asked the details of the surgery, kept on nodding, and especially when it was spontaneous because of her sore throat, when she coughed, and you said, do you need a glass of water? That was so spontaneous. This
Right.
presence of mind I need from you guys. It's not a template, guys. I don't want that you copy paste a template. You should be able to handle the patient. I mean, when you handle, you're saying, do you need a glass of water? So that was very, I would say, accurate presence of mind, which I was looking at. Now, you did say in the middle in the history that cyst is removed, but in the management, we forgot that. So patient safety got affected. Cyst versus ovary. This is what I wanted to be very clear, because this was the applied clinical knowledge. So here I saw Shweta's eyes also on the candid instruction that, when you said that, I see your one ovary is removed, she was also looking at the, where did she get it from? You asked the medical, surgical, family history. That was very good. And I liked the tone. Everyone, please pay attention. Fadi, did you notice? Asya saying, For you guys, it might be a tiny thing, but for the examiner who is looking at communication with the patient, is a very good acknowledgement, nodding, and echoing. Please write down in your notes when you do three things.
Yes.
Number one, nodding. Number two, when you make affirmation sounds, and when you do echo, any one thing. For example, she says BMI 24 and you say 24. When you echo one thing, these three things make your graph of the communication with the patient immediately very, very high. And this is a very solid score. And I want you to learn from today so that your communication goes way too higher. I was
Yes.
happy with the smear question. Thank you, Fadi. Double hormone she was taking. That was because of contraception, probably. One patient safety question. Is it preventive for borderline ovarian tumors, guys?
No. No.
Any sort of
No,
evidence?
it is not.
No.
Otherwise,
No.
it's preventive for the ovarian cancers.
Yes.
It
Yes, it is, but it doesn't hold true for the bot.
for the it is
So
not.
this is a very important point that you guys need to know. As per the British recommendations, we say for the patients who are BRCA or even the patients who have the ovarian cancer, family history, personal history risk, we say that it is protective to take the combined pills. However, specifically if in exam, this
For
is
the
what I picked
Cs.
up from the TOG article. See, now I'm making stations. So in the TOG article, if it's borderline ovarian tumor, you should know that here no evidence links up the safety. So I'm expecting when you'll have lots of curriculum in your head and you'll have ovarian cancer and ovarian cyst, malignancies as a case scenario as well. And this would also be a case scenario. You might forget this point. So please remember, here COCPs have no evidence-based link of protection. However, for the ovarian malignancies like epithelial cancers and other cancers, yes, it is protective. Please remember this point because we are preparing the TOG article stations. I want you to prepare your notes and a separate notebook for that. You did Breaking Bad News, could have been a little more better. I mean, in terms of warning shots, you confirmed the name and the NHS number. That was a very good patient safety. I was happy when she was asking question and you were saying it's a valid question. So acknowledgement was there. After completing family, the management would have been the complete surgery. That was okay. But also now, if it's cystectomy, it has to be unilateral salpingo-oophorectomy. We had to come to this point. At least borderline ovarian tumor has to be treated now. Coming to the points to improve, ladies and gentlemen, please pay attention here. We started this story with talking with Anna Roberts with you are here today because you have got your histopathology here. So she might not understand histopathology, okay? 2 times in the station you have spoken this word, one in the start and one after breaking bad news that your histopathology says this. So your laboratory report
Report.
says, okay, all of you, this is a better statement to speak. Your laboratory report has been provided to me and it says, Claire, Asya, got it?
Yes, ma'am.
Now, somewhere in the history, you spoke that I was not in the surgery. I don't know what was that point. Somewhere in the start, after agenda, you said I was not.
Actually,
Yeah, what was that thing? I want to.
Shweta just went away. I was like about to tell her that I was not in the surgery. I would like to ask that did they discuss anything about surgery? From there, I should be taking the thing that maybe a cystectomy done or something else they want to know. But
Makes.
I just skipped that point. I don't know. It just
Okay.
vanished from my brain.
I have one very strong suggestion which I have to make it today because you have to understand that information that is with you is candidate instruction. We
All
can't
right.
make the story out of it. We can't reduce the
Mhm.
story from that.
Okay.
Here, it's not written that you were part of the surgical team. It's not written that you were not part of the surgical team.
And
So
it will be occipital to anterior. So remaining 10%.
So basically, what I want is that you should not be making the things out of it.
Mm.
If some information is not given to you, you don't speak that information. It's better. If
All
you
right.
want to say, Asya, that what was the procedure done? So the better statement was to speak, Shweta. All right, Anna, if I could know the details of the surgery that's been performed, did somebody talk to you after the surgery and somebody discussed with you? What are you aware about the surgical details? So, your starting point. Rather than this statement, I was not there, I'm somewhere from the outer team. So, I am actually personally I'm against extra statements because they can put you in difficult situation in exam, not to invite any difficulty. So it's better that you just speak whatever is given to you. In exam, if at all it happens cutting the role play, 2 times it happened in the start that Asya was also speaking friends and Shweta was also speaking. Then Shweta was also speaking Asya. In the beginning, both were speaking together. I realized that it's because of online Zoom. In real exam, all of you please note down this point. Cutting the role player is a sin, and you don't have to cut the role player. If you cut the role player, your communication with the patient immediately goes dip. Now, there is a chance that, suddenly you guys speak. I mean, both have in mind and, you speak together. If at all this happens, look at me. I'm sitting like this and I'm saying something like, all right, about the surgery. And immediately the role player also speaks. I would be immediately changing my position, bending forward and saying, yes, please, I'm listening to you. Go ahead. Immediately stop and cover the point there and then because examiner is noticing. Instead, if role player becomes quiet and you complete your sentence, imagine that your communication with the patient would go in a dip. Understood, everybody? Is this
Yes,
point
ma'am.
noted? Right?
Yes.
This can happen unintentionally, right? Intentionally shouldn't happen. You see that, the lips about to move for the role player, you should be quiet. But if you feel that it has happened, it's all right. Quiet, yourself quiet, bend forward, which is like a positive sign that you want to listen to her and say, yes, please, I'm listening to you. Please let me know. Clear? Everybody? This is what I expect. Shweta wants to say something. Shweta?
Ma'am, I have one question that uh, as a candidate, I can cook up the story like when I'm saying that I would like to go through your notes, and what I see in the notes that you were taken up for an ovarian cystectomy, but because it was a large cyst, the ovary was also removed. So
How?
that makes my
How can you
station
say
easy.
no? How can you make this if it's not written that oophorectomy is being done? This is my question.
Okay, we can't make that.
You
Okay,
can't make that because this info is
okay,
not with you. So you can't say maybe if it's cystectomy, then you have to do oophorectomy. And if oophorectomy has been done, then the treatment has been done. You can refer her for the fertility center.
okay.
But
Okay.
If it's not given to you, you can't make it because you don't know what the role player has been informed.
Yeah,
You get
right.
it? Right? So you can't
Okay.
cook the story because that would make you go towards the direction where it might be a treatment plan. Maybe USO is a treatment plan.
Hmm.
Okay, got it? Now I've
Okay.
written histopathology report. You can again say laboratory report, completing the family patient information leaflet, support groups. You couldn't reach out to that point because we couldn't complete the station by that. Now, the only thing which I was concerned about was the applied clinical knowledge. This was a role player and she did not have children. She was asking, do I need chemotherapy? These questions all I have made from the talk articles. Can I still have children? There is a chance that it might come back, doctor. Will this affect my life expectancy? All these questions you should be knowing about the answer. Is this a cancer? Why did this happen to me? What happens next? Do I need further surgery? This question I specifically made. If at all it is a cystectomy, then yes. Answer would be yes. Okay. If at all USO has been done, then you can say at the moment, because it has been stage 1A, the things have been cleared and no further surgery at the moment is needed. After completion, the family will keep a very close surveillance for you, Anna. All right. Will I be followed up? Yes. This is what Asia did beautifully about the tumor markers and about the ultrasound as well. Okay. These questions you should be able to answer. All right. Anna Roberts is here. You're going to acknowledge that she is here with you today and you're going to confirm that all her concerns are addressed. Hello. Hi. I'm Dr. Asia. I'm one of the doctors in the clinic today. May I confirm your name and age? Is it okay I call you Mrs. Roberts? Thank you for seeing me today. I can see that you're quite anxious and you've had a surgery for some fluid collection cyst in your ovary. Am I right? I'm here to address all your concerns and talk to you about the same. I've been provided with your reports as well. Before I begin, may I know that somebody talked to you about the surgery and the reports? So now your starting point that, what is she knowing about? This is very important in exam. This gives you a direction because the role play has got highlighted points. Whatever is the answer, most probably she will be saying that, I'm sorry, doctor, I'm not knowing the details, so that, the station moves forward. All right. Can I ask you questions to know more about you? Before we begin with the details of the condition, if I could know that how's been your recovery? How are you feeling after the surgery? Any pain? Any sort of a fever? Any discharge? All right. If I could confirm that, when did you start feeling this fluid fill collection? When was it diagnosed? What exactly happened before the surgery? I see. I'm sorry to hear about this. Remember this statement, guys. I'm sorry to hear about this. This gives you immediate score in the communication with the patient. Few questions regarding your periods. Are they regular? And do you have children? Any past pregnancy, Mrs. Roberts? And do you plan to have kids? I see. All right. If I could know about your smears and the past history, any sort of a hormones you have been taking? All right. Any other medical problem for you? All right. Any family history of concerns specifically for the ovarian or the breast cancers in the family? Any surgeries on the tummy or down below apart from this recent surgery? Do you smoke or drink alcohol, Mrs. Roberts? And pardon me asking, any recreational drugs at all? How had you been feeling in the last few weeks and months? And how's the support at home? What do you do to live? Thank you very much. Quickly, if I could double check your BMI weight to height ratio in your blood group. All right. Thank you very much for all this information. I would like to examine you in the presence of a chaperone, if that's okay. Thank you so much. Now, my first intro, agenda, and information gathering is done. In information gathering, two very important points which I have seen for the patient is that how had she been in the recovery, her symptoms in terms of the condition, where I would definitely cover her weight loss. Please note it down. For such cases, we say any unintentional weight loss. And do you feel any change in your appetite? Note it down, friends. Rokaya, Fadi, all of you please note it down. Aisha Jadoon, Zilehoma, any unintentional weight loss for you? And may I know any recent change in your appetite? This is the statement which you're going to speak for the for any sort of cases where you have a pre-malignant or a malignant lesion. Now you have done your 5 minutes of the station, right? You have to make sure that you check for the understanding side by side. Your communication with the patient is without jargon. Histopathology you can say as a laboratory study. And you make sure that you are very safe in your applied clinical knowledge with the MDT, right?
Mm.
When you reach up to the applied clinical knowledge, you have to tell, I can see that you're here alone today. Would you like somebody to be with you? I'm afraid that I have a difficult news to discuss with you today. I've confirmed the name and the NHS number on the laboratory report that has been provided to me, and that unfortunately reveals that there are some abnormal cells that has been detected in the cyst that has been removed. We call it as borderline ovarian tumor. I'm extremely sorry to inform you that it's not normal or a benign cyst in which we do have concerning features. However, it is not cancer at the moment. It does not invade the surrounding tissue like cancers they do. Having said that, it does need treatment immediately because it can transform or it can have a recurrence. It can have the spread in the body parts if it develops into the cancer and if it's not treated. At the moment, it has a better outlook, and 95 out of 100 women, they are alive for many years when they are diagnosed and treated in time. This line is taken from the talk article. Okay? She immediately says, now the surgery is being done. What is the treatment? So you tell them that as per the staging that's been done, it is confined to the ovary, single ovary, and it has not been seen. The abnormal cells have not been seen in any other part. Because in the candidate instruction, what was the stage? Remember, friends, same stage is for borderline ovarian tumor, which we use for the malignancies. Okay, so you have to say, you don't get confused. The same staging you have to learn for the CA ovary and for here as well, right? But you would say, unlike ovarian cancer, we do not need cancer-killing medications after the surgery because it is a borderline state. It has been caught early, Mrs. Roberts. The tumor has been removed. The next steps are surveillance. Now, this line you would speak when USO has been. Okay, now here is a presence of mind. We can't have a template. Here you would see if the role play tells you cystectomy, then you would say the team of doctors will decide. We need to have the removal of that affected ovary and the tube, keeping the other ovary healthy and intact so that you can complete your family. If she says unilateral self-endophrectomy, my tube and ovary has been removed, so then you say that the treatment is complete for the borderline ovarian tumor. However, we would do surveillance for further treatment. Now, we would consider keyhole surgery if at all. First, it was only cystectomy, guys, for USO. Here, I wanted the applied clinical knowledge where Asya had already presumed that it's been done. Here, you will decide how, according to the role player's response.
Role play.
If role play says only cystectomy, then you will do a keyhole surgery and you would also tell about the washings and check other areas that there's no spread. If this has been done, then you will reassure that current treatment is sufficient for O. It actually is accurate for the state. Got it? Okay. Now she wanted children. So you're going to reassure her that's absolutely possible. We have fertility sparing managements of the borderline ovarian tumor with single ovary, tube intact, and no other fertility concerns. The pregnancy is possible. Because of this concern and having the borderline ovarian tumor, we can refer you to the fertility center so that they can take the steps for early pregnancy possibilities to discuss with you. All right. Now, after this, you're going to mention about having the regular ultrasound scans or tumor markers to monitor the recurrence, given in the, again, talk article. Recurrence can happen, Mrs. Roberts, in a small number of cases. Usually in the ovaries, we monitor closely. If any changes are there, we have to treat it promptly. Anytime during the follow-up or in your upcoming months or years, if you have any new onset of pain, any bloatment, or any changes in your tummy, please see us without any delay. This is the biggest patient safety point where you tell her about the red flags and the follow-up when she has to come back immediately. Talk article says, friends, you will have a long-term follow-up for several years, and we would involve the gynecological oncology team who are specialized in these tumors. I can see that you're very worried searching online. This isn't same as that of ovarian cancer. The outlook is good, and we make sure that you're supported at every step with us. I will give you a very detailed patient information leaflet. We'll connect you to the support groups. We'll refer you to the fertility center, keeping in view that you want to have a baby, and we'll have a very close liaison with the team of doctors and the follow-up for you. Is that okay? Do you have any further questions for me? Now she says in exam, why did I have it? Is it something which I did? What would be the answer? Anything? Yes.
There's a little genetics involved with it, no? The BRAF gas pathway. So can we say that?
In the family history, she says, I didn't have any family history positive.
Gotcha, right.
Anyone? Zakia, Ruqayya, Zilihuma, Aisha Jadoon? Anyone? She says that, is it something which I have done?
No, not.
No.
You can reassure borderline ovarian tumor is not something where you're going to mention about that there's something which she has done or she could have done to avoid this to happen, right? But because this has happened, now the surveillance is going to be for her. Please note down these patient safe points which I've written. Borderline ovarian tumor, not cancer. Excellent prognosis. Fertility sparing management appropriate for the early stage disease. MDT and follow-up with ultrasound and markers. This is must to be spoken. This is the biggest patient safety and applied clinical knowledge. No role of adjuvant chemo and radiotherapy, please, in borderline ovarian tumor. Remember, please, no platinum, no carbotaxel, nothing is to be mentioned here. Also, the recurrence possible but low safety net. Carefully, you have to tell about red flag signs that she should be knowing. Now, the best candidate would be the one who is very clear, structured, very excellent reassurance about this, accurate knowledge, and telling patient-centered approach. If you're unsafe in borderline ovarian tumor, the only trick is what surgery has been performed on her. This would make you patient safe. Is it a cystectomy or is it unilateral salpingo-oophorectomy, please? Got it, everybody? Now, if the same station comes as a structure discussion, because now we are preparing the talk article, right? So you're going to take the case scenario as, what have I taught you? SBAR. I have a 34 years old woman undergoing laparoscopic cystectomy for what was thought to be a benign ovarian cyst. The frozen section has confirmed a borderline serous tumor. My priorities are to avoid the tumor spillage, tailored surgery to her fertility wishes, and ensure appropriate staging and MDT involvement. Opening line. Okay. So intraoperative priorities in patient safety, you will mention about avoiding tumor rupture, irrigate and aspirate, and peritoneal washings if they're not done. Inspect contralateral ovary, peritoneal surfaces, omentum, diaphragm, and document the findings for her. For the surgical management definitive is surgery, bilateral salpingo-oophorectomy, hysterectomy, omentectomy, with or without staging biopsies if she has completed family. And if she has not completed family, unilateral salpingo-oophorectomy or cystectomy, if performed already, it's okay. If not performed, then this would be the treatment. Right? Got it, Asya? Omentectomy, peritoneal biopsy, and washing for stage. This is very important. This is what we did in Mrs. Robin. That is preservation of contralateral ovary and the uterus. Okay. In this case, she's young and has expressed the fertility wishes, so I'd not proceed to the hysterectomy or contralateral oophorectomy. If staging expertise is limited, may defer the formal staging to a second planned procedure at a cancer center, depending upon what expertise is available. Communication with a colleague in the structured discussion. Friends, remember MDT, discussing the findings with the consultant interoperatively. It has to be referral to the gynecological oncology, MDT, outpatient consultation to discuss the findings and knowing about this, the patient is aware about the counseling, about the details. Follow-up would be explaining to the patient that borderline ovarian tumor is not invasive cancer, but it requires long-term follow-up. Follow-up with pelvic ultrasound CA125, 6 to 12 months. Fertility preserving approach carries slightly higher recurrence risk. Why? Because we are leaving one ovary, but better prognosis. And if recurrence occurs, it is usually manageable surgically because we have the other ovary and the hysterectomy would be done in that situation. Okay? Remember that for exam, these points are important for your exam. Making sure that you guys are very, very clear for each domain. Communication with a colleague. Do not miss out multidisciplinary team. And patient safety, do not miss out that if cystectomy had been done, it had to be unilateral salpingo-oophorectomy for fertility preservation. Otherwise, complete staging bilateral salpingo-oophorectomy with it. If you remember these points for borderline ovarian tumor, you'll be very, very clear. But if she says, I need chemotherapy after that, what would be the answer, friends?
No, they are not chemosensitive. They are chemo-resistant.
Very well done. And we don't need it because the treatment, because they have excellent prognosis, we don't need to step up after that. It is for the ovarian cancers. So this is 2025 borderline ovarian tumor published on 12th of September for the October publication, friends. We are going to come up first with all the October talk articles. We'll complete their station so that you're very clear, you're not blank in exam. See, this is the staging, same as that of an ovarian cancer. You should know about the benign and malignant features as I've taught you in MRCOG part 2. Histopathology might be given. The pictures are not given in exam, but they might give the histopath report. So you should be knowing about that if fertility sparing is required, then in that situation, unilateral treatment would be done. If fertility sparing is not required, then bilateral salpingo-oophorectomy complete would be done in that situation. Know about the serous and mucinous. The only thing is that in mucinous, we do consider the appendix as well. If it is
swollen,
very well done. We say macroscopic changes are there.
Microscopic changes are there.
Very well done. I do not expect that the recurrence score would be asked, but you should know that recurrence is higher, of course, when the patient is more risky in terms of more CA125, when the histological type is higher, or when it is unilateral salpingo-oophorectomy. Yes. So in your patient, Asia, if cystectomy is done only and you don't do highest recurrence. Can you guys link up now? How wrong was the patient safety? So we should be very clear. If it is unilateral salpingo-oophorectomy, risk is higher, but if it's only cystectomy, risk of recurrence is even higher. So that's not an accurate treatment. And if it's bilateral salpingo-oophorectomy, that's the best thing with the least recurrence, of course, because everything is removed in that case, right? Okay. I have few mnemonics for you guys just to make things easy for your memory. Remember, fertile. So remember for borderline ovarian tumor, because I have to make you guys ready if at all a new station comes, fertility sparing options. E, early stage, mostly borderline ovarian tumors are picked up in early stage. R, it's always a surgical excision, at least unilateral salpingo-oophorectomy, bilateral if the family is complete. Then you know T, through thorough staging, we are going to do the risk assessment. Staging is must to know about that we have to go for bilateral or unilateral. For 1A, unilateral is sufficient, and generally borderline ovarian tumors are picked up in unilateral time or in the early time, please. Then we have long-term follow-up always for them, and stage 1 is picked up. It is excellent prognosis. All right. Okay. So remember, fertile as the mnemonic for memory for borderline ovarian tumor, F-E-R-T-I-L-E, and these points are your patient safety points. Then for histology and clinical pointers, remember SAM Hist, Serous type is most common. So it is expected that they'll give you histopathology serous because it's more common. You have to mention A for histopathology. Abnormality is there, all of you. The cells
But no
lining is
stromal.
abnormal, but no entering, no
Stromal.
invasion into deep as like cancers they do. Please remember for histology, for the structure discussion, everybody, I need your attention. After the session, you should be master in borderline ovarian tumor. You have to remember that most common is serous and second most common is mucinous. And then you should know it is holeless, no stromal invasion is there. Eye implants are possible. Still, peritoneal involvement can be there in borderline ovarian tumor, friends. That's why we take washings. Right?
Mhm.
You should not have this feel that is borderline. It is not going into stroma. But students, they feel, ma'am, it's not a cancer, so no peritoneal involvement. Borderline ovarian tumor can have peritoneal involvement, guys. Implants can be there. That's why we do complete staging during the surgery. Right? Typically, stage 1 is found. And here, for the diagnosis, tumor markers are not very reliable for borderline ovarian tumors. Okay, so SAM hist is the memory for your histology. Serous being most common. They are atypical but no stromal invasion. Mucinous is second most common. Holeless, or we say that no stromal invasion. Implants are still possible. Typically, we diagnose that on stage 1 and tumor markers are generally unreliable.
Unreliable.
Very good. Now, stage beyond 1. Remember the mnemonic stage luck for the prognosis. Stage beyond 1 is high risk, friends. So when we do thorough staging, we have better outcomes because we pick up the diagnosis in the stage. Younger age, always fertility concern, so we do USO. Early picked up, good prognosis. Extra ovarian implants, they worsen the risk and the prognosis is worsened. Remember, long-term follow-up is needed. Unilateral versus bilateral, definitely prognosis is better if it's single ovary. Right? It's understandable. It's a common sense that if it's a single ovary, that is a better prognosis. And complete excision of the ovary, removal of the ovary is better than the cyst. Okay? Histology words really matter in borderline ovarian tumor. If they've written something like micropapillary and microinvasion, that would give us the most important points. Now, the last 3-4 slides are the summary, which you guys have to remember for structure discussion and for SPT. So when we close this topic, and if new topic comes in May 2026 from the 2025 TOG articles, you are mastered in that. Remember, borderline ovarian tumors are epithelial ovarian tumors showing epithelial proliferation, atypia, but no invasion, right? You should know that most common are serous, and then we have mucinous as well. Peritoneal implants can be there. Symptoms can be vague for the simulated patient task, like it can be pelvic pain, abdominal distension, mass, and most of the time, incidental ultrasound finding can also be there. We do imaging, which is very important. TVS is important. CA125 may be normal or very slightly modestly raised as well. So staging is very important. During the surgery, definitive diagnosis is definitely on the histopathology. Most of the borderline ovarian tumors are stage 1, right? And very good prognosis is there. Recurrence risk is there, but depends upon the factors like stage or invasive implants, or the staging has been incomplete.
Staging is incomplete.
Very good. So what is the mainstay of management? It is the surgical removal with appropriate staging. Fertility sparing surgery is unilateral salpingo-oophorectomy. Cystectomy can also be done, but would not be preferred. Why? Because the recurrence score will get very high with cystectomy. Remember the table which I've taught you? USO would be the preferred one. In post-fertility women, radical surgery or hysterectomy and bilateral salpingo-oophorectomy plus staging would be done, right? Adjuvant chemotherapy is controversial, no clear benefit, so we can reassure her that generally radio or chemo is not needed here, but follow up long-term with regular clinical examinations imaging ultrasound, tumor markers for several years would be done for her. Very well done. Remember that borderline ovarian tumor behave less aggressively than invasive ovarian cancer, but they do require still appropriate stage. Histopathology is very important, and you will always get a question where the age would be fertility preservation, so that you have to hold on the complete surgery. They would 100% give you a reproductive age group for borderline ovarian tumor. They would never give you a patient who has completed a family, because they want to test that, how do you do USO, how do you refer, and they would see that that how the fertility preservation is done in that case. Okay, so my important point which you have to do as a take-home message is that for borderline ovarian tumor, the expected station, always integrate patient's age, fertility wishes, tumor subtype, staging completeness, implant status into your decision making. If you remember this block, you would never miss out any case on borderline ovarian tumor. Clear, everyone? Yes? Thank you so much. Thank you. Any questions, please? Anything which is not clear? We have managed the whole borderline ovarian tumor. Would like to continue? Please feed back with this. Doing these talk article stations, is it a good thing? Or do you really think that you will be having less anxiety of the new stations approaching May and taking each station from the talk articles from the May 2026 exam starting from October? Yeah? Is it a good idea? Or do you want to do?
Yes.
Do you still want to do
Yes,
the
it's
calls?
Good idea.
it's a good idea.
It's a good idea to do the publications of the talk article so that everything is in your brain, and when the new station comes up, you're not blank. You're able to handle the expected scenarios. Yeah. All right. Thank you very much. Thank you, Aisha Jatoon. Because everybody knows now, even in this exam, repeated station, everybody knows. But a slight change is like you're blank. Oh my God, ma'am, this was not prepared. This was out of curriculum. So out of curriculum stations are affecting your new stations as well, which is like, it, but station number 1 gets affected because it's a recent talk. So 2, 3, 4 gets affected, it, but it gets affected because 1 was new to you. So, subsequent stations start getting affected. So that's why we thought that, your confidence should really be good. Recordings would definitely be available. Thank you very much, Zelihoma, for liking the effort. And we'll put it on YouTube. I'm going to put a channel on the YouTube with the talk article station so that you can scan with captions. Click and open, click and open. So what my aim is that your all 2025 publications are complete before your exam. So that would October, then May, then April, and then, I'll go back. So basically, if any new station comes, because expected stations we're already doing in the regular and the fast track, right? You'll be mastered in them. There are 250, 300 stations which we are doing. But the newest expected stations, which they come like 3 or 4 from the talks, so you would be mastered in that. And at least your reading would become easier from the talk. Right? Okay, thank you very much. Thank you. I will be doing the next one regarding the placenta accreta spectrum because that has come also in October. We'll announce the date and time in your study groups and in the open group as well. Any questions, please?
Excuse me.
Ma'am, I have one question, ma'am.
I'm here for the questions, please. Yeah.
Excuse me.
Ma'am,
Yes, Fadi, I can hear you.
If in scenario there is a bilateral one and patient want to preserve fertility, can we do USO and cystectomy in the other side?
So
Preservation.
it is going to be risk versus benefit. Her health is important on fertility. So we can give her other fertility options for this, but MDT decision would be there. It depends upon the stage, Fadi. It depends upon the MDT decision that can we put her life in risk, the spread can be more, or she wants to have a baby, so we can give her other fertility options when the oophorectomy is done, right? So in this case, tell her pros and cons and tell the team of doctors will decide the best, keeping the risks and the complications expected. Okay?
Thank you so much.
Thank you.
And is there any
I have
talk
a
of
question
placenta
here.
accreta?
Like if this patient in her primary surgery would have had spill, during
Yeah.
laparoscopic removal, like it's a big tumor. So how do you counsel now, and what will be the prognosis?
So if at all it's a mistake, then it is going to be an incident report, Banashri. It is going to be a complication, so you will accept and do the duty of control. I'm sorry that a complication has happened. As per the notes that there have been some spillage, we'll be very open, honest, and transparent to you after we gather up the data and investigate the matter thoroughly. And the chances or the complications I can expect is that it can have a spread of the borderline ovarian tumor. In that case, the implants can be there. The team of doctors will discuss about the prognosis, but we would be getting back to you after the investigation gets completed. In this case, if it's USO, we might have to need further BSO or hysterectomy as well. But it depends upon what MDT decides. So the best thing is that it has to be the team of doctors discussion. But accept your mistake, do the duty of control, do the incident report because it's a complication. Okay.
Okay. Thank you, ma'am.
Thank you very
Ma'am,
much.
in this case, hello, ma'am. Ma'am,
Yes,
in this case, if patient fertility is completed, after that we have to do BSO and hysterectomy also,
yes,
and
it should
stop
be done.
and
It should
stop
be done.
the
Stop the.
and stop further investigations.
No.
So now it depends upon that if we can do lifelong surveillance and she's going good, we can go with the TVS and tumor markers. Again, if any symptoms happen or any expected complication happens, we can do the surgery. Or after the family is complete, we can still have the MDT discussion that prophylactic surgery is okay for her. This all these options are available depending upon how patient responds, how she is in terms of her symptoms, what is her age, and then MDT decision, my dear.
Okay, ma'am. So if we do a hysterectomy and BSO, after that we can stop doing further TVS and tumor markers, right, ma'am?
Yes, because bilateral serpingophorectomy is done, right?
Right, ma'am.
We'll,
Thank you,
we'll
ma'am.
be telling her these symptoms like red flag signs, any abdominal discomfort, any
Absolutely.
bloating, any weight loss, and then you can come back to us.
Absolutely. We will always tell the red flags. We'll give her the patient information leaflet. We'll connect her to the support groups. All these things speaking gives us score. It gives us marks. Okay. All right. Aisha Jadoon, it was in 126. They got the next time. Anybody who wants to volunteer, I'm happy to take. Even you guys can do. So anybody can tell me, whosoever wants to present can do the next time. Okay. All right, I will write in the groups again, the timings, and for you guys, all of you. So anybody can do the presentation and we'll write the topics as well. In fact, we'll make the complete schedule for all the mentors and the list of the talk articles so that you can make an index and you can do tick, 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 tick. Okay, side by side, this is getting prepared. So we'll make sure that the coaching series is with you guys in terms of the index. So probably in 2 to 3 days, we'll give you the complete index with the dates so that you can make your schedule, and one station we can do one talk article. All right. Thank you very much. Thank you, everybody. Thank you for attending. I was not thinking that it would be again a massive attendance. Thank you, Abira Malik. Thank you, Anju, Asma, Aisha, Manashri. Thank you, Divakar. Good to see you, my dearest. Thank you. I've received all the videos for you guys as well. Farah, thank you very much. Khushbu, thank you. How's everything going? Naila, Rashmi. Thank you, Sadei. Thank you very much, Zo. Zakia, Zarvin, Zile. Samya, thank you so much. All right. Thank you, Lolwa. Always happy to have you, my dear. Thank you so much, everybody. The recording would be uploaded. If any questions, any concerns are there, we'll be back with the next talk article with you guys. And again, we'll try to cover it as a simulated patient task and a structured discussion so that if anything new comes, you guys are amazing and you guys are very confident to reproduce that. We should not only aim passing in May 2026, we should aim very, very high score. And I'm super proud of your efforts in the study group. Thank you very much. Bye-bye, everybody. Take good care. Thank you so much, everybody. Best of luck from the entire team of RFA Tutors. Thank you so much. Bye-bye. Take care. Thank you.